Welcome to the next webinar of ERN GUARD-Heart. It's the 9th webinar of this series. Today we have our speakers from the Rotterdam Erasmus Medical Center from Rotterdam in the Netherlands, Dr. Annemien van der Bos and Dr. Mieke Driessen, and they will present cases about adults with the transposition of the great arteries. And I would like to give the word to Annemien.
Yes, thank you so much for the introduction. I will share my screen with you. And I hope you all, it doesn't, yeah, there it is. So good afternoon, and thank you for the introduction to show you some cases on transposition of the great arteries, and especially the adult population. And transposition of the great arteries is actually a very serious problem. The big problem is that the two main arteries leaving the heart are reversed. And in this talk, we will talk about complete transposition of the great arteries, the so-called dextro transposition of the great arteries, and not the congenital corrected ones. So with the transposition of the great arteries, actually, the systemic venous blood is directly returned to.
Oh my God.
I hear some voices. Maybe you can mute. Thank you. So the deoxygenated blood is actually pumped again through the lungs, and the deoxygenated blood is remained in the aorta. So you have a circulation that is actually not possible to maintain for a long time. So there is a really history about operation, the transposition of the great arteries, and it is shown here that in the early stages we had atrial switch operations that were the mustard and the ascending operation, and actually now in a new era we have the arterial switch operation. And I will show you a case about mustard operation patient, and Mieke will talk to you about arterial switch operation. So I will actually present this case as a patient journey or a patient story. It's a patient that we see regularly in our outpatient clinic, who is a 41-year-old man who was born as a blue baby, as we call it, and it was found to have a detransposition of the great arteries. First, a balloon arterial septotomy was performed so that we could have some mixing in the early phase of the oxygenated and deoxygenated blood. And quite early after that, a mustard correction was performed. Then a baffle is actually constructed in the atria, where we see that the blood from the superior and inferior caval veins is directed to the left atrium and left ventricle, and this left ventricle is actually connected to the pulmonary artery. Then the oxygenated blood returns on the right atrium side, goes to the right ventricle, and this right ventricle is connected to the aorta. Now, the problem is in this operation and also in the ascending operation, that this right ventricle will perform as the systemic ventricle. By the age of 5 years, there was an obstruction of the inferior baffle. And this is not the same patient because we don't have the images anymore. At the time he was 5 years, but this is from another patient, and I will try to guide you through these images because it's always difficult to find your way in a patient after atrial switch operation. So in this still frame, you see here, this is the right ventricle, this is the left ventricle, and here you see like a border. So here are the pulmonary veins entering, and the blood is actually directed, this is the pulmonary venous baffle, into the right atrium going to the right ventricle. And the blood from the systemic venous circulation actually enters here on behind here in the left atrium going to the left ventricle, and then is pumped into the pulmonary artery. By angulating your probe more to posterior, you will see here the inferior baffle coming into your image. So here we have the inferior caval vein going, the blood enters here the left atrium and going to the left ventricle. You can do that from an apical view, but also from a pernosternal view, as is shown here. A pernosternal view, and here we have again the inferior baffle directing the blood to the left atrium, here to the left ventricle, and here we have the right ventricle in front of us with the tricuspid valve. So this patient had a inferior baffle obstruction, and there are a few signs that you can be aware of, and that the first sign is that when you look at the inferior caval vein, you won't see normal collapse because you have elevated pressures in your inferior caval vein because of the obstruction in this baffle. And here is very nicely shown. You can see the iliating and also just in anatomy, you see here narrowing of the inferior baffle. So at the age of 5, there was a balloon dilatation performed. During catheterization, they also find a mild obstruction of the pulmonary venous return, but that didn't need any treatment. So the rest of his youth, he was doing pretty well and didn't require further surgical or percutaneous interventions. Unfortunately, he was lost to follow-up for several years, and that is a problem we see a lot in our adult population. And ultimately, he presented in our local emergency room at the age of 26 with a supraventricular arrhythmia, so atrial flutter with a very rapid ventricular rate. And he was not feeling very well with it, and this is his ECG. So he needed actually electrocardioversion to sinus rhythm. And then we have this classic ECG of a patient with a transposition of the great arteries. You see normal sinus rhythm, a normal P wave, but a really right axis with high voltages of right ventricular hypertrophy, and also this typical strain showing also a sign of right ventricular hypertrophy. The echo at that time showed some, moderate to severe right ventricular dilatation, some reduced right ventricular function, and here in the short axis, this typically flattening of the interventricular septum, showing not only in systole, but also in diastole, reflecting the pressure overload of this systemic right ventricle. So the following years, he has actually recurrent supraventricular tachycardias. He was treated on with beta blockers. He was treated on sotalol at that time. We even treated it with amiodarone, but actually every time we had recurrence of supraventricular tachycardia. And because he is so young, we didn't want to have him on amiodarone for a very long time. So multiple ablation procedures were performed. And eventually there was a complete substrate modification in the systemic venous atria and an incomplete substrate modification in the pulmonary venous atria. And electrophysiologists find these patients quite challenging because they often need to puncture the baffles. And you really need sophisticated software to map the baffles. So on an electrophysiological point of view, these are challenging patients not only because of the complex anatomy, because it is a transposition, but also to get at the right place where you need to do your ablation. At that time, the gradient in the pulmonary venous baffle was actually 12 millimeters mercury, so that was quite okay still. After all these ablations, he did actually pretty well. we had a kind of a honeymoon phase between 28 and 35 years of age, with no real major concerns, and maintained regular follow-ups now in our adult congenital clinic. He maintained a regular job, he got married, he had 2 children, and actually exercised regularly. But closer to his 36th birthday, he noted that he became more fatigued and running, when he was running his normal run 2 to 3 miles. So we put him on a bike, that's what we do in the Netherlands, to see if there were any desaturations or arrhythmias present during exercise. And this is what we found. The exercise test actually revealed that a baseline saturation was 92 with room air. And there was a significant desaturation to 86% while cycling. And there were no rhythm disorders. So he was very intensively imaged, and on echocardiography now we see a baffle leakage. And I hope you can see this. I will guide you through this image. Here we have the inferior baffle again going to the left atrium, and here you see, and here's with color, you see actually a kind of a bidirectional shunt, and here is a baffle leak, and here is the right atrium, tricuspid valve, and the right ventricle. This leakage was closed with an ASD Amplatze device. Sometimes also a stent can be performed, but this is a very known a place where we often see these baffle leakages. So he remained fully saturated and continued to do his work and his exercise, often without no concern. And we followed him because we were still worried about how this right ventricle will keep functioning throughout his life. And I have here put in some MRI data for over the years. And what you see is that over the years, his right ventricular function and ejection fraction is actually slowly decreasing. And on the other hand, we see that right ventricular volume is increasing over the years. However, his left ventricle, so his subpulmonary ventricle, is still quite functioning quite okay, but we do see also some dilatation here. So now we are more in the present, because 2 years ago he came in again and he said, I'm not doing well, I'm more tired, I have more dyspnea complaints during exercise. So we put him on the bike again, and now we found that his heart rate didn't really rise. His heart rate of 89 beats per minute only went up to 100 beats per minute, and also his peak VO2 is really reduced. So because of that, we concluded he had a chronotropic incompetence, and a transvenous pacemaker was implanted. Well, you can discuss about, do you really want to have a transvenous or epicardial pacemaker? Of course, when you want to have an epicardial pacemaker, you have to do another surgery, and that can maybe in the long run put his chances down for getting a heart transplant. However, the other way is when you put in a transvenous pacemaker to sometimes a very small baffles, again, obstruction can occur. So there's always a trade-off, but in this case, we put in a transvenous pacemaker. So this pacemaker goes through the baffle into a left ventricle. Our electrophysiologists always use a screw to screw the lead into the left ventricle, because otherwise it's often displaced. We found in that moment there was no indication for an ICD. Also, he didn't show any ventricular tachycardia during exercise or on halters. Well, then we continue, and you see here an image from actually almost 1 year ago. And what we now see is a really reduced right ventricle. Here we have this very dilated ventricle, dilated right atrium, tricuspid valve, and I think we all can agree that he now has a poor right ventricular function. So what can we do now? Of course, we look first to, can we reverse things? How is his AV valve regurgitation? Well, it was only really mild, so we couldn't address that. There were at that moment no atrial ventricular arrhythmias. We investigated him again on baffle obstruction or leakages. There was nothing present, and he had mild pulmonary hypertension. So we put him on actually standard heart failure medication. And that means we also used Entresto, and we also used dapagliflozin. And that actually helped. This is his NT-proBNP levels and the course over the years. So he was in 2015 around 60, and we see then in the last year we see a small increase over the years, with here a peak. So when he came in and really were in heart failure. By treating him with all this medication, not only his symptoms decreased, he felt better, his exercise tolerance increased, but also it was clearly seen in his NT-proBNP that dropped significantly. Although he again now, and this was his last visit a month ago, he again had atrial arrhythmias, and therefore we saw again a small increase of his NT-proBNP. So what options do we still have? Well, can we do resynchronization therapy? I'm a little bit in doubt. It's always very difficult. Does he need an ICD? At this moment, we are monitoring him with his pacemaker. That can also with home monitoring, and we haven't seen any ventricular tachycardiums. So we still think he doesn't have the indication for an ICD. Also because a lot of these patients actually die from heart failure and not from sudden cardiac death. We are now planning for already screening him for heart transplant or maybe a right ventricular assist device. And I think the switch conversion therapy, so that you do a doubles, so you undo the baffle construction and you do a atrial switch operation, is at this stage and also in the adult population not a real option in these patients. So we have a very young man, so 41 years old, with actually now severe heart failure, and hopefully we can manage and see if he is a candidate for a heart transplant. I thank you for your attention, and I would like to continue and give the floor to Mieke.
Yes, thank you. So I will see if I'm able to share my screen. I think everybody now sees my presentation. So I want to talk to you about the arterial switch operation. So the next procedure that was developed for the transposition of the great arteries, and hope to share with you that it goes better than in the patient we've just seen. Let's see if I can go to the next. Yeah, this is just a short reminder of when the arterial switch operation came into place. In most hospitals in the Netherlands, they started doing arterial switch operations in the 1980s, and about 1990, everybody had switched totally to the arterial switch operation. So most patients are at most now 40 or 45 years old, so the follow-up is not that long yet. This is a schematic review of the operation, really. So the child is born here with the aorta rising from the right ventricle. and the pulmonary artery rising from the left ventricle. Then the great arteries are dissected at the level of the sinotubular junction. And of course, the coronary arteries also need to be removed from the right ventricle outlet and transposed to the left side, which was actually the most tricky part of the operation, and also the reason why in the early days of the operations, a lot of the children died because they developed ischemia. And then the aorta is placed to the back and the pulmonary artery is placed to the front. And it actually sort of overrides the ascending aorta. So the left pulmonary artery goes on the left side of the ascending aorta, and the right pulmonary artery goes on the right side of the ascending aorta. This is a 3D CT scan of a patient that had the operation done, just to show you what it looks like in adulthood. So this is the pulmonary artery, both branches, which sort of are like two legs around the ascending aorta, which is displaced to the back a little bit. So you see that the aortic arch also gets a very different shape than usual, much more Gothic. And in this patient, there's also some dilation of the first part of the neo-aorta, which is what's called after the arterial switch operation. So I have put in a couple of questions just to keep you awake. I think you can share the answers in the comments. Just, I don't know how many of you work with patients after arterial switch operation, but what would be your estimate as to how many re-interventions are done at 25 years of follow-up approximately? Do you think A, about 5%, B, about 10%, C, 15%, or 25%? So at about 25 to 30 years of follow-up, how many patients have had either a recath intervention or resurgery? Don't know if people can actually share something. Yeah, so it's going B, C, and and Anamin shares D, so we know what the right answer is. Yeah, unfortunately, it's not very low. There have actually been quite a couple of studies in the last 10 years showing the more long-term or mid-term follow-up. So it was started by Kyrie in 2013. I think I had about 15 years of medium follow-up and maximum of 25 years. And the newest study that was published in 2023 by Van der Wijk have follow-up actually until 45 years of age. And actually all studies show a similar pattern, that at 25 years, about 75% of the patients is free of re-intervention, but that also means that about 25% of the patients has needed a re-intervention. The most common reason for re-intervention is a stenosis somewhere in the right ventricular outflow tract. So that can be either the pulmonary truncus valve, but more often the pulmonary branches that are narrowed. The second most common reason for re-intervention is a neo-aortic root dilation. So the first part of the aortic root obviously is still the pulmonary artery, because the first part of the great vessels is not switched, and that tends to dilate and then lead also to neo-aortic valve regurgitation. Coronary occlusion and stenosis is also described as a possible complication, but it's infrequent. It's about 2% only in different studies. And there is some reports also of LV dysfunction. About 3 to 4% has a decreased LV function at follow-up, but that's not a reason for re-intervention yet. Just to show you also the differences in the population, on the left-sided panel, so this panel, you can see the difference when patients have a simple transposition of the great arteries, so no concomitant defects, which is the black line, compared to patients that either have also a ventricular septal defect or even more complex, the Tausig-Beng anomaly, in which there's also pulmonary stenosis. So re-interventions are much more frequent in patients with concomitant cardiac defects. On the other side, on the right side, you see in the study by Van der Wijk, they actually divided their follow-up into two categories: patients that were operated after 1990 and before 1990. Group A is the group before 1990. In the beginning, a lot of them had also a two-stage arterial switch. So they first had a pulmonary bending and creation of an ASD, and then when they were older, got an arterial switch operation. So this meant much more re-intervention in the early operative phase patients than there is in the current patients. So I'm also going to take you to actually two cases of patients after arterial switch operation. The first one is actually 30 years of age. Also was lost to follow-up because he thought at age 18 that he was done. He actually only has the transposition of the great arteries and arterial switch operation in his history, no operations after that. And he actually came to the outpatient clinic because he was always a very sportive person, did a lot of sports, played hockey, running, but actually had complaints that he wasn't at the level of his teammates anymore, even though he had been able to compete at their level before. His blood pressure was 130/50 and his heart rate was 80. So we did an ECG. This is the ECG actually showing sinus rhythm. The axis is still normal, and infralateral there's negative T waves. And we proceeded to an echocardiography, and here we always start subcostally, and you see the abdominal aorta, and also a pulse wave in the abdominal aorta. And I was wondering, what do you see on these pictures? Does the pulse wave show a normal flow pattern for young adults who still has very good elasticity of his abdominal aorta? Do you think it might be fitting with severe aortic regurgitation or a patient that has a concomitant coarctation? So I don't know if you could, I'll go back to the picture. So this is the picture of the pulse wave. And I think you can share again in the chat. Oh. Oh, no answers yet. Then I'll show you the right answer in the next image. So these are echocardiography images, which are unfortunately not perfect because after operation, sometimes in adulthood, it's very difficult to get good images. But here you see a parasternal long axis, the right ventricle. Here you see the beginning of the left ventricle. And here you see with color Doppler at the level of the neo-aortic valve that there is a regurgitation. Here you see the three-chamber view. And you also see regurgitation. And on this view, you already see that it seems dilated, the ventricle, and the function is not perfect anymore, especially regarding the fact that he has a aortic regurgitation. This is of a patient that has better image quality on parasternal long axis. Here you see the neo-aortic root, so that is still part of the pulmonary root originally. You see that it's dilated, which makes the valve asymmetrical, and there's a severe regurgitation here. So for our patient, we also did a CMR, and these are two of the images. So here you see a three-chamber view showing aortic regurgitation and also showing a very big left ventricle. This one won't play. And we measured actually his left ventricular end diastolic volume at 0.5 liters, and the ejection fraction was 48%, so it was severely dilated. And this is a CT scan performed in the same patient preoperatively. I'll take you through it when it runs again. We go from the top to the bottom in the patient. Here you see the ascending or the descending aorta, the pulmonary artery and the pulmonary branches. And here you see the neo-aortic root, which is actually slightly dilated, but mostly asymmetrical. so we concluded it's a symptomatic severe neo-aortic valve regurgitation, and there's some neo-aortic root dilation, which is often the case in these patients, and we treated it with a Benzel procedure for this patient. So after the arterial switch operation, the neo-aortic root dilation is something we need to monitor for, mostly because it's also associated with the valve regurgitation. The Gooch guidelines recommend that replacement may be considered at a diameter of more than 55, but that's based on the normal aorta, basically. And this is obviously a different situation because there's actually already a surgical suture above the aortic root. So we don't know if they will dissect and what the consequences might be in these patients. I don't think there has been any dissections in literature so far. And for the aortic root the aortic valve regurgitation, we follow the ESC guidelines for valvular disease, which means that you operate if there's symptoms, or if you see that the left ventricle is no longer able to accommodate the regurgitation, which is what we did in this patient, obviously, who came a little bit late as well. So the second patient is actually 28 years of age, had the transposition and arterial switch operation as a neonate, and at age 1, I think, already had his first balloon angioplasty for pulmonary branch stenosis on both sides. And at age 5, he had stents placed in both pulmonary arteries. After that, he remained intervention-free, and he just came for a regular follow-up, had normal exercise capacity and no cardiac symptoms. On physical examination, we did hear a systolic murmur actually on both sides of the sternum and also radiating to the back. His EKG is actually just showing sinus rhythm, a vertical axis, and some intraventricular conduction delay, but otherwise looks pretty normal. And this is his echocardiogram. He's also challenging to get everything into one picture, but this is an attempt for a peristernal long axis with a good left ventricular function. And here we see the neo-aortic root and valve. And here above it, you can see actually the beginning of the pulmonary valve. So this is a little bit tilted in the peristernal long axis to get that pulmonary valve into view, but this will change with every patient after arterial switch operation, and it's always a challenge. So we try to get his branches in a good view in the peristernal long axis. This is a sort of a short axis of the aorta, trying to get the pulmonary artery in the picture, but as you can see, we didn't really succeed. He had some TR though, and we were able to measure that gradient, and it was increased. It was 3.4 meters per second. So his right ventricular systolic pressures were about 50. So these are just some pictures to show you how you can visualize the pulmonary artery in patients after arterial switch operation, but you have to basically just be very creative and try all of these non-standard views. So this is a 3-chamber of the left ventricle, and if you tilt it more anteriorly, hopefully you'll get the pulmonary arteries, as you see in this patient. This is not from the same patient, obviously. And here you see a peristernal long axis where you also tilt it a little bit towards, or flat, put it down a little bit towards the right in the hope that you'll get the pulmonary artery in that picture as well. And here you also see some stenosis above the valve. So in our patient, the image was pretty poor, but we were actually able eventually to visualize his pulmonary arteries. This is a picture of the left pulmonary artery. In the middle, you see the aorta. Here's about the positioning where you expect the right pulmonary artery, and here you see the left. And pulse rate actually was about 3.6 meters per second, so there was still a relevant stenosis in the stent of this patient. Just to show you how you can sometimes get the branches in these patients, it's basically a short axis of the aorta, and you go up 1 or 2 ribs in the hope that you'll see the ascending aorta in the middle and the pulmonary branches crossing on either side of the ascending aorta, as is depicted here. Well, it's back to our patient. Actually, his right ventricular function was good, left ventricular function was good, and we performed a CT scan to look at the stents that were already in place since childhood. This is again the pulmonary branches. You see the stents here, and if we go through it again, I will show you that we actually didn't see any stenosis now somewhere in this stent. So in conclusion, we have an asymptomatic patient. We also put him on a bike. He performed actually very well with 35 mils per kilogram, which is 100% of what was predicted. He does have a bilateral pulmonary branch stenosis with an RVSP about 50%. And he has a good non-dilated right ventricle with normal function and no significant TR. So my question to you would be whether or not you would perform an intervention in this patient. A, yes, and B, no. Okay, I don't think anybody will respond. We actually, let's see if I can go to the next one. If you follow the guidelines, then intervention should be considered if the RVSP exceeds 60 millimeters mercury, and you can do a percutaneous intervention. Obviously, if there are symptoms, or if you see a decrease in RV function or TRs increasing. Regarding pulmonary branch stenosis, they actually suggest an intervention at an earlier level, about 50 millimeters mercury, or whether if you have a significant mismatch in perfusion, for example, if the left lung is getting only 10% and the right lung is getting 90%. But that last criterion is something that's usually mostly used in childhood, because in adulthood, well, both lungs have already formed, so they're not gonna grow less or more if you dilate it in adulthood. And actually in the patient I just presented, because he was doing so well and had stable measurements for about 10 years now, we decided not to do an intervention. Also because we didn't see any real narrowing in his stent, so that didn't seem to be a good substrate for intervention. So in conclusion, I think the number of patients after arterial switch is going to be increasing in the following years. We don't know what the real long-term follow-up will be. It's not infrequent that these patients need re-intervention, and the oldest ones are only 45 years now, so we'll see what the future brings. I think for echocardiography, it's a challenge to get a good, mostly to get a good view of the right ventricular outflow tract and the pulmonary branches. It's also important to focus on the root dimensions, the neo-aortic valve regurgitation, and the LV systolic function. And I think in most patients, at least one time a CT or CMR is recommended to see whether echo missed something, especially regarding the branch stenosis or the size of the aortic root, because sometimes it's just difficult to get it perfectly in your echo. So I think that's it for the arterial switch operation. I don't know if people have questions.
Thank you very much, Mieke. Yes. Are there any questions regarding the atrial or arterial switch patient? I don't see anything also in the chat.
No.
Well, then I think we I like to wrap up. I hope we've showed you the big variation of patients with transposition of the great arteries in the adult population. It's truly from the heart failure to valve problems, a lot of arrhythmic problems. So it's a severe disease, not only in childhood, but especially also in adulthood. and we are, well, looking what will happen to our arterial switch patients in the next decade, if they will have more interventions. And on the other hand, we are really afraid of our patients after atrial switch operations, who now actually almost all are going into heart failure, and it is very difficult to treat them properly. Thank you very much for your attention and that you attended this webinar, and hopefully we'll see you in the next webinars. Nienke, can I give it back to you? Do you have any announcements?
Thanks a lot, Annemien, and thanks a lot, Mieke, of course, both for your very interesting and very clear presentations. And although we didn't have many participants, I hope many of the ERN members will go back to the recordings later on the website. So thank you for your attention, for those who were there today with us, and we're looking forward to meet you next month again. Bye-bye. Have a nice day.
Bye.